high PRA. Okay, so as we know, the presence of a raised panel-reactive antibody is considered as a marker of high risk of acute rejection. Okay, and patients with high PRA are considered to be highly sensitized. Usually, we consider patients with PRA above 20% to be at a high immunological risk. So we decided to do this study to assess the difference between the outcomes of ATG and basiliximab in those high-risk patients with PRA greater than or equal 20%. And the condition was that the patients are maintained on tacrolimus and MMF therapy. Okay, so our study was exempt from IRB because it was performed on publicly available de-identified data. We used the data from the UNIS database. The UNIS database is a national database in the US containing the data about all organ transplants actually done in the US, including kidney transplants, liver transplants, heart and lung transplants. So we used the data from September 2017 to September 2019. The data was retrospectively reviewed and the follow-up was until March 2020. So we set up some exclusion criteria, okay? We excluded all patients less than 18 years old. We excluded organ transplantations other than kidneys. We excluded multiple organ transplantations. We excluded patients who are not maintained on tacrolimus, and patients who are not maintained on MMF, patients with PRA less than 20%, and patients with missing induction therapy at time of transplantation. So we collected the following data. We collected data about the age, gender, ethnicity, delayed graft function, diabetes, BMI, cold ischemia time, number of previous transplants, panel reactive antibodies, donor type, donor age, HLA mismatches, induction therapy, and maintenance immunotherapy. So what we did is actually that we divided the patients with PRA above 20% into 3 groups. Okay, group A with PRA ranging from 20 to 49%. Group B, the PRA range was from 50 to 79%. Group C, the PRA ranged from 80 to 100%. And we divided each group into 2 arms, the basiliximab arm and the ATG arm. Okay, we did the regression analysis to assess the effect of ATG and basiliximab on the acute rejection episodes. So we compared both arms in each group as regards the number of rejection episodes within 6 months after the transplantation. So what did our results show? Our results, for example, as regards group A with PRA 20 to 49%, we had 2612 patients in the group. 517 patients received basiliximab induction, while 2095 received ATG induction. Both arms there was no statistically significant difference as regards the number of acute rejection episodes between both arms. As we can see that the p-value is above 0.5 and the confidence interval is actually crossing 0. So there is no statistical significance between them. So we concluded that in patients with PRA less than 50%, there is no difference between ATG and basiliximab as regards acute rejection episodes. As regards group B with PRA from 50 to 79%, we had 2,309 patients. 311 patients received basiliximab induction, while 1998 patients received ATG induction. Again, there was no statistically different significance between both arms. The p-value was high, and the confidence interval actually also crossed 0. So also there was no difference in the rejection episodes between both arms. But in the third group, the results were different. The third group is the most highly sensitized group with PRA from 80 to 100%. In this group, we had 4,374 patients. 284 of these patients received basiliximab induction, while 4,090 patients received ATG induction. In this group, there was actually a statistical significance. The p-value was less than 0.01, and the confidence interval ranged from negative 0.72 to negative 0.1, so it's not crossing zero. So here there is a statistically significant relationship between basiliximab, ATG, and the number of rejection episodes. The risk of rejection episodes was lower with ATG induction compared to basiliximab. So our conclusion was that when the PRA is less than 80%, there's no significant difference between ATG and basiliximab. But if the PRA exceeds 80%, there is a significant risk of acute rejection episodes is lower with ATG induction. And since ATG is known to cause stronger immunosuppression and cause a higher risk of malignancies and higher risk of opportunistic infections, so our recommendation from this study is that basiliximab induction may be considered till PRA less than 80%. However, we of course need further studies to confirm our findings. Thank you.